How did you get the bird sounds and the classical music? How are you, Simone?
Not too bad.
Not too bad? Excellent. Busy? You're at work today, aren't you?
Yeah. Yeah. I work Tuesday to Friday, so by Friday I'm done.
Yeah, me too. I work Friday's now my day off. Off. What's that?
Off.
Uh, but I find like if I don't know, Thursday afternoon, I'm like, yeah, it's Friday. And then it gets to Friday, I'm like, tutorial meeting, blah, blah, blah. Yeah.
Not a day off. Not a day off
Not a
when you
day
start with this.
Exactly. Well, it is nice, actually. I really enjoy doing this. So, and I hope nobody minds, but I feel like if I prepare very intensively, then I've got like an idea of we need to get through all of this stuff, and it ends up being a bit rushed and people don't get out of it what they actually want out of it, as far as like being able to ask questions and stuff like that. So I hope nobody minds that I don't do a heap of preparation or slideshows or anything like that. But yeah, this is the way to make it sustainable as well. So today we are supposed to be talking about like biopsy, centesis, cytology preparation, and essentially keeping pathologists happy. There isn't actually, I mean, everybody's doing all of this stuff already, so I don't want to spend too much time on that. And last fortnight we were talking about POCUS exams, which everyone was very interested in. And Jeff requested that we go through the thoracic, like a thoracic aspect of that. So if everybody's happy to start with the T-POCUS just to flow on from the last tutorial and then talk about the cytology stuff afterwards. Happy? Excellent. Okay, so we talked about the POCUS exam, so point of care ultrasound exams, essentially having in your mind a question that you're trying to answer. So rather than going, I'm just going to cast a wide net and see what I discover when I look in the abdomen or thorax, where what we're trying to do is answer a specific clinical question. So when we apply that specifically to the thorax, what questions might we want to have answered in our emergency presentation case?
Is there pleural effusion or not?
Yes, good. Effusion. Plural effusion. I'll put on there.
Is there a pericardial effusion?
Yeah, thank you.
Or air is the other thing.
Beg your pardon?
Effusion or air.
Air, exactly. Perfect. So I think they're probably the three main kind of respiratory presentations. Like, are we dealing with an acute respiratory crisis because of pleural space or pericardial space disease? Not that pericardial effusions typically present with respiratory, but you know what I mean.
Don't overlook the value of percussion for picking up pneumothorax.
Do you know what, Jeff? I reckon that's a lost art. I reckon there are people who are amazing at it, but if you don't do it regularly and know what normal sounds like, you can't detect abnormal.
Yeah, you're dead right. And I even had a client criticize me because I was thumping his dog.
It's tricky. It is tricky to do actually in the like consult setting with clients there and stuff. So therefore, I think people tend not to do it regularly in the normal patients, and therefore our ability to detect abnormal decreases. And I love that point actually, because with ultrasound, the more normal you look at, the better you are at detecting abnormal. So everyone sort of says, oh, I only want you to check the bladder when I go to do ultrasounds, or I only want you to check the kidneys because it's azootemic. But the way that I do ultrasounds and train ultrasounds is if I don't check every other organ in that abdomen at the same time, then I won't know when the next patient has an abnormal gallbladder because I haven't seen 7,000 normals. So I do encourage people to kind of have a system and follow it for ultrasounds. That doesn't really apply to point of care emergency ultrasounds. That's more just for kind of if you're engaged to do an ultrasound, doing the normals is actually a service to your patients, your future patients. Point of care ultrasounds, we're just looking for the problems. We're looking at pleural effusion, pericardial effusion, pneumothorax. What else might we see on that?
Pulmonary edema, which is evident with B lines, but some
Right.
are normal. So you need to know that your point intake, that you need to know what is normal to point out what's abnormal.
Yeah, agree. Okay, so they're probably the main things. Like, and I'm gonna kind of broaden that out, like pulmonary edema, pneumonia, collapsed lungs, consolidation, all of that stuff. I'm gonna put that into like primary pulmonary disease. But it's a very effective tool when you've got a patient with acute presentation that isn't stable enough to be held in lateral for a radiograph. And to get an initial impression of like, okay, well, this is like probably a pretty big deal for the clients and therefore going to be this much money and blah, blah, blah. Or this looks pretty straightforward. Rarely acute respiratory presentation is straightforward, but you then know you need to tap them immediately to stabilize them to be able to then do the further tests and stuff. So does anybody have a system for looking at a thorax in an emergency situation?
I percuss the chest first. It's quick and it's easy and it's informative.
Yeah.
Not sure how sensitive it is, but I've heard it said that it isn't. But then
Well, I think that's user dependent, isn't it? I think you're probably quite attuned to the abnormalities.
yeah, if it's a duller than normal, I mean, the normal lung's got a really rich sort of tympanic sound to it. Pneumothorax has got a very hollow, like you're hitting a drum.
Wow, interesting.
And if there's fluid, it'll be dull.
Yeah.
But when I did my fellowship exams, I could see the dog had something wrong with its chest because it was clipped, and I could see a spot where they tapped it. And I was able to delineate the fluid level by percussing it.
Oh, right. Well, that's cool. Did you actually have dogs in your fellowship exam? Real dogs?
Yes.
Wow.
It was part of a series of tests, actually.
Yeah, it'd be hard to make sure you had the right case at the right time. That makes setting the exam quite hard. Very different now. Just do it off pictures. So first thing, assessing. So obviously when they come in, we're going to have listened to the stethoscope discussion and kind of assessed respiratory rate, effort, type of effort as well.
Yeah,
So
like pattern.
yeah, the respiratory pattern I think is so informative. Again, if you've got in your mind noting what's normal, and then this patient, I know this patient has laryngeal collapse, this is a tick patient, and I know that's a very distinctive obstructive breathing pattern, upper respiratory obstructive breathing pattern, and things like that. So once you get this patient on the table, they're on oxygen, and SpO2 is 85, and you're like, oh, I don't want to do anything with it. What are you going to do with your ultrasound machine? Where are you going to look?
That's a good point.
So I typically do 5. I don't know if this is the correct order, but I typically start dorsally. So then looking more for you could definitely see sometimes pleural fluid there, but potentially more in pneumothorax or B lines or a step sign if you're looking for primary pulmonary disease. So I kind of go dorsally, then more ventrally, and then I typically do a subcostal one particularly if you're worried about volume overload, and check the caudal vena cava.
When you say subcostal, is that on a lateral subcostal or is it subxiphoid?
I kind of go right lateral, although I guess you could sort of do it from anywhere the dog's or the cat is most comfortable.
Yeah.
Because I'd typically go sort of on the right, but I actually think you could probably do it from either.
Yeah.
specifically for looking at the caudal vena cava.
Yeah. It's the only thing about going subxiphoid. So Helen said, I don't know if this is correct. There is no correct. It's basically there's a million systems that people have like come up with. This is the way I do it. This is the way I do it. There's no right or wrong, but essentially you want to be assessing a dorsal lung field, cranial thoracic inlet kind of lung field over the perihilar region, and also ventrally. So where you're seeing kind of the heart, but then just caudal to the heart, just cranial to the heart ventrally, because they're the pockets where the early bits of fluid collect. And so if you think about those, I want to assess those regions on both sides. And the ways to do that, there's different ways of putting the probe on the animal, and there's no right or wrong way of doing that. But just having a little map of like, these are the sections of the chest that I want to check. If I'm looking at a deep chested dog, I'm very rarely going to try and find the cava from a subxiphoid approach. You'd have to have them lying on their back. You'd have to have them really deeply sedated to be able to push hard enough to get close enough. And then you're pushing so hard that you're actually compressing the cava a lot of the time. So that right, either subcostal, but again, if you're subcostal, you're pushing on the cava and you can compress it and alter its your assessment of it. But looking down through the ribs through that right dorsal kind of approach can give you a nice caval view, which just helps you with your assessment of pericardial effusion, for example, right-sided congestive failure. Okay, so I did put some slides together. I did it 3 weeks ago, so let's see what's in them. Okay. Can everyone see?
Mhm.
Okay, so just wanted to review the kind of anatomy of the thorax as we see it for the different problems kind of thing. Everybody's very familiar with looking at a radiograph. But when we're looking on ultrasound, let's start with the caudal aspect of the thorax, so the diaphragm, pleura, caudally. So if you put your probe on here in a healthy animal, what should you see?
A diaphragmatic line.
Yeah.
Hyperechoic.
Should it be still or moving?
I should be moving.
Moving, exactly. Yeah. So if you're back here and you're looking at the right-hand side of the dog, you're going to have liver on half of your view, and you're going to have lung in the other half of your view. And what's that lung doing? As they inhale, it's going to move backwards, and as they exhale, it's going to move forwards. Does anyone know what that's called?
Is it the Gerson sign?
It's the curtain sign. I was waiting for someone like, duh. So what that is essentially is like you're looking at the liver and you're getting a really nice view, and the lungs just keep going in your way, and you've got to time your image to look between the lungs. Because what does a lung look like on ultrasound?
A hyperechoic line with
Yeah.
nothing behind it.
It's big grey fuzz. Yeah, exactly. So what does that tell you? If you've got lung going over your view like this, and you can see that lung moving relative to the chest wall, what does that tell you about the presence of a pneumothorax versus a normal lung?
I think if it's moving normally, then that's a good thing. That's
Yeah,
normal.
that's not a pneumothorax, right?
There's
Yeah.
not a pneumothorax, exactly. So that's where if you've got a pneumothorax, the air is just sitting inside the thoracic wall and it's not moving relative to the thoracic wall with inspiration and expiration. And these dogs have typically got increased respiratory effort, so they're taking big breaths and you're not seeing any movement. Oh dear. So we're initially going to put our probe on back here, depending on what we're worried about. Again, with T-fast, if you're going to get one view, you go for what you're most suspicious of, right? So if you're most suspicious with pneumo, then you're going to go dorsally because air floats. We're going to look at that caudal margin of the thorax and along this dorsal margin of the thorax. Going to be the most sensitive for picking up a pneumothorax. What about cranially? What do we see up in this kind of section that we would be interested in an emergency situation?
Like aspiration pneumonia.
Good. Yeah. Cranial lung lobes. Aspiration typically Up here or down here?
Ventral.
Ventral. Good. Yeah. Most of what they aspirate is heavier than air, so it goes down. Just gravity takes it to the lower areas. Oh, lower areas. Whoa. Oh, sorry. So aspiration pneumonia, so pulmonary changes, we can see absolutely here. What is, oh my gosh, I need to stop fiddling with it. I'm gonna sit like this until we're ready to change slides again. What about the pink line there, which delineates the ventral margin of the lung? The significance of this is that this is what actually provides us with a window to assess the heart. So what do we know about the anatomy of the left lung lobes? How many lobes are they?
Like left cranial caudal, and then left caudal.
Yeah, so pretty much 2 main lung lobes. So the window on the left-hand side is not as forgiving as the window on the right-hand side, where there are how many lobes?
Right has cranial, caudal, and then middle and accessory. So
Accessory.
you can't really, can you really see accessory? I thought you couldn't really see.
No, on a radiograph. Apparently cats get pulmonary edema in the accessory lung lobe first for some reason. So sometimes in early pulmonary edema you see the accessory lung lobe, you go, oh, there it is, but that's the only time you see it. So that little notch on the right-hand side between the lung lobes is bigger. And this is why we start our echoes with the patient on the right-hand side. As the heart falls down towards the wall and actually it can push more of the lung lobes out of the way. In an emergency situation, you're not going to be able to lateralize them a lot of the time. I mean, sometimes if you're dealing with cardiac disease and they're not in respiratory distress, but a lot of the time you're looking with them in sternal, and the heart's sinking down to the bottom of the chest, and it's going to push the right lungs more out of the way than the left lungs. So that's the significance of that pink line, because if you've got lungs sitting over the top of your heart, you can ask Helen how annoying that is. I've been training Helen to do echoes. It will completely obscure your view, and you won't be able to see what you're dealing with. What about if you've got a pericardial effusion? What will happen to that window that you've got to look at the heart?
Should be bigger.
Yeah, exactly. So bigger heart is going to push more lungs out of the way. It's going to displace the lungs, and you should be able to see it a lot more clearly. So if you're seeing all lung, you can sort of say, well, it's probably not a pericardial effusion. And then that ventral pleural border down the bottom is actually just the pleura, but it's a really nice little window where we can see early pleural effusion when an animal's in sternal. So just at the cranial kind of notch of where the heart meets the lung, and just caudal to the apex of the heart as well. What? What? Okay. Sorry. Okay. So that's the kind of that's the anatomy of the chest. Now, there's not really a firm system for doing a TFAST. As I said, there's lots of different proposed ways of doing it. But what I would sort of say is keep in mind where if you're sort of going respiratory distress, I really don't have an inkling whether it's an effusion or pulmonary edema based on the respiratory pattern. This is the kind of the areas that I want you to kind of think about assessing is caudodorsal, particularly looking for pneumo, perihilar, particularly looking for pulmonary edema, cranial, again looking for effusions, and middle, where you can assess the heart and for evidence of effusions as well. In reality, I'm probably like to go a little bit more ventral than those are shown on the image there, just because I like to see more heart, because that's where my comfort zone is, and more likely to see effusions. This is a terrible image. Sorry, I had to take a photo from Edinger. Did anyone read this chapter in Edinger? It's like, this is such an emerging, exciting tool, and the chapter's like 3 pages long with like images like so small you can't even see them. It's like they've obviously just said, oh, you get 3 pages, And it's such an important field. Anyway, I guess it's not medicine strictly. Okay, so let's have a look at some of the images of what we're going to see when we put our probe on that position 1 cordodorsal aspect of the chest. So obviously they're labeled, so I'm not going to test you, but bones are dense. The ultrasound waves won't show up, won't go through. So we put our probe on longitudinally, so the light is pointing towards the head. And we've got our probe between 2 ribs. So you can see the 2 ribs here and here. Then we've got a normal pleural line. So that bright white line. Then we've got underneath that, just a big fog of white. So this is what they call the bat sign. I don't know why they call it that. He's drawn like a, you know, what's his name? Serge.
Sorensen.
Yeah, Sorensen. Sorry,
Yeah.
Sorensen. He's kind of really pushed this technique and he's like training people worldwide and doing it, which is excellent for the animals. But he's a really great teacher if you want to watch any of his YouTube videos. They're an excellent resource. Anyway, he's drawn a really nice bat over this, which makes sense, but when you look at it, it doesn't really look like a bat. So then when we look at that and look at what sort of artifacts or what sort of variants of normal we might see, these A lines, what are they?
And they're normal, but I don't know what
Yeah, they're normal. Are they, is it just like reverberation or something?
Exactly. Yeah, it's just a reverberation artifact. So essentially the ultrasound's like, I should be getting something back, probably like here and here. It's completely normal. And one of the ways that we can kind of differentiate peritonitis, the presence of gas in the abdomen, to be able to see A lines in like a bladder, for example, or within the peritoneum. So then, ooh, where's my B lines? Okay, so can anyone tell me what a B line is?
Well, it's a vertical white line instead of a horizontal.
Correct. So it looks pretty similar to the image I've got on the right here. See that? So the key thing with B lines is that their origin is level with the pleural line. So this isn't actually a B line. This is an artifact from some area of abnormality in the lung. So how many B lines is normal?
I think it's less than 3 sort of a thing. And then if you have like 3 in any lung, more than 3 in any like one area, because you can like segmentalize it, that's considered abnormal.
Yeah. And what does that signify?
Edema, some sort of edema. Like
Or smells. It could kind of be anything else in the lung.
Yeah, it's fluid, basically. Increased fluid in the lung. So the key things are that they move with the lung. So that tells you that they're in the lung. They're not an artifact from outside the lung. They have to extend from the pleural line right to the distal end of the image. And they should obscure the A lines. So they're the kind of things that you should look for. If you're seeing vertical white lines, the things that you should look for to say, okay, this is like, there's less than 3, this is probably normal, or there's more than 3, and there's quite a few of these, there's probably a little bit of pulmonary edema here. So say you had a dog that came in with a grade 5 murmur and respiratory distress, no pleural effusion on your ultrasound. Where is the position of the cordodorsal, cranial, perihilar, ventral, where you're most likely to detect your perihilar edema? Oops.
Perihilar.
Good, excellent. So you're going to see increased number of B lines. but that is the area where the chest is the widest. So a lot of the lung affected is actually quite central. So pulmonary edema, in my experience, has to be quite bad before we're seeing it at the periphery of the lungs. Yeah, I like to, the rest and respiratory rate is still the most sensitive test for development of pulmonary edema. Okay, so that are kind of normal things. I've talked about the curtain sign, and I didn't name it, but the glide sign is that movement that we talked about, where the lung is moving relative to the thoracic wall. So you can see that the air is in the lung rather than just in the chest cavity. So that's a nice thing to just note when you put the probe on the chest. So then when we start to talk about abnormalities, this line, well, I'm going to jump straight to the image on the right because I've been referring to that as the kind of example of a B line. This looks exactly like a B line, but so just that little notch or abnormality in the lung border tells us that it's probably something that's actually structural within the lung that's causing that B line rather than that normal kind of edema within the pulmonary tissue.
So like a little nodule at the edge of the lung or something?
Yeah, it's pretty poorly demarcated, like this one. As in like it doesn't look dense like tissue, but there's like, yeah, something on the edge of the lung, which could be just fluid, but yeah, it's definitely causing deviation of that pleural line. And then this image on the left-hand side of the screen. Does anyone want to tell me what sort of disease processes you might expect that?
So this consolidation of the lung, like it's called a shred line, and typically you would see that. I think atelectasis can also do this, can't it? Or not really?
It can, yeah. So consolidation of the lung can be due to infiltration of the lung with inflammatory cells or fluid or pus or whatever, or due to like any collapse of the lung. Anything that pushes the air out of the lung. So what in this image, we've got just a tiny bit of pleural effusion. See the pleural line there, and then the lung margin there. And what about these little bright spots here? What are they? It says it on the image. Oh, wow. I did it again. So has anyone ever seen consolidated lung on an ultrasound?
Like I've seen this shed sign, but I don't like,
Yeah.
I'm not sure if I'm not necessarily thinking consolidation because you're mostly doing this in cases where you are actually thinking this pathology. Whereas atelectasis will only come in if you have made the animal recumbent. It's not going to be there if the animal hasn't been recumbent.
Yeah, well,
Or can be.
really fat dogs, like if they're like if when you say sort of they've been recumbent, that they're lying on their side, but really large breed dogs, they're not filling up their entire lungs all the time, so their ventral lung fields can be quite compressed. It's not like, yeah, it's not going to look like this. See how this is quite focal. Atelectasis tends to be kind of across more of the lung and less well circumscribed, so it's not just one little kind of chunk like that. And then this shred sign that you mentioned, what defines a shred sign?
Like the way I have thought of it, I don't know if this is correct, but I've just thought like, because how your normal lung looks like, this will have, like there'll be a bit of a step and there'll be some stuff there.
Yeah.
Yeah, like this steps.
It's essentially a really irregular margination to that region of consolidation. So you get this kind of like, it looks like someone's kind of torn it rather than like a smooth margined nodule, for example, which looks more like this. So what this shred sign is where aerated lung meets consolidated lung. So we can see the air is causing that big shadow that we always see when we're looking at air. But then this area is actually letting the ultrasounds through. And we can see regions of aeration within that lung, which are those little air bronchograms. And that's what tells you you're looking at lung tissue, or one of the things that tells you you're looking at lung tissue rather than a pleural mass or something outside of the lung. What else could tell you that you're looking at something inside the lung? When you're looking
Pleural
live.
line.
It
Pleural
could move,
line, yeah.
it will move with the lung tissue
Yes. Yeah, exactly.
as
So
they breathe.
yeah, it's really clear when you're looking live. It's awful looking at a still image and going, well, I don't know, but live, it's moving with the lung, which means it has to be in the lung. So has anyone ever seen a nodule like this in the lung?
Yeah.
Mhm.
Hannah, sorry to interrupt, just to go back
Yeah.
to the last slide.
Yeah.
Is that from a traumatic lesion?
This one?
Yeah,
I don't know, actually. It was
Okay.
just an example of the shred sign.
sure.
So this is, I should actually credit, these images are from Sorensen's references. So it's just available online. I just Googled them. They're freely available. But they are excellent images. If you want to go through, just have a Google, and his YouTube videos are amazing.
He's actually come up with a book for it. Like, I think he's released a book. I have not seen it, but I think there is a book.
It wouldn't surprise me. Yeah. For emergency clinicians, I hope it's really in. Very, not too many words. Excellent. Okay. So you can very clearly see the difference, right, in the imagination of a shred sign or a consolidation versus a nodule. So much more likely to be neoplastic if it looks like this. The annoying thing is that often nodules will like not be at the periphery of the lung, or they'll be kind of blocking a bronchus upstream, and then you get consolidation distal to it, like a bronchial carcinoma, for example. So it blocks the airflow into that lung lobe. So sometimes you see quite a like rounded part and then a really messy part, and you're sort of going, oh, is it a neoplastic cause of consolidation, or is it just consolidation like aspiration pneumonia or something?
When you see that nodule, would you aspirate?
Yes, I'd aspirate both of these.
Okay.
I love lung aspirate.
You don't worry about creating a pneumo or causing a bleed.
Oh, I do. I do worry about it, but I do it
Okay.
anyway.
But you still do it. Okay.
If you think about the way that we used to tap chests, like we're so spoiled using ultrasounds. There's actually, I don't think it's that, like it definitely happens and it's not a safe procedure. It's one that I take great care and do under careful ultrasound guidance with a lot of training. But I actually think it's quite hard to create a pneumo of significance with a needle hole. Like it's not like I'm kind of hanging out with air and a needle and not watching it and letting the lung like slice over it or anything like that. If they're jumping or moving, then I'm aborting mission and giving more sedation. And I'm going in with the breathing and pulling out with the breathing and, you know, very, very controlled. But I think it's so informative and so minimally invasive with very low risk relative to other opportunities we have to sample the chest. And particularly in cats where they get that weird like nodular lung changes. It could be toxic, it could be hematogenous pneumonia, could be lympho, probably need to know. So that's kind of the only opportunity we've got.
What does a bulla look like? Like in a differential for this spear bulla?
So what is a bulla?
Like just airfill. Or should I call it cavity? I don't know if I should call it.
Yeah, it's almost like an air-filled cyst sort of thing in
Yeah.
the lung. What causes bully?
Can't they be spontaneous too? And there's obviously some pathology.
Yeah, so there's a couple of different causes. So one is that there's a genetic like defect in the strength of the cartilage in the lungs. So as soon, you know, they do a cough and the lower airways go instead of just normal kind of staying nice and tapered. But by far the most common cause of a bully is actually obstruction further up. So in cats, asthma, the leading cause, or bronchial constriction of whatever cause, and in dogs, chronic obstructive pulmonary disease. So what a bully actually is a very extreme kind of version of like bronchiectasis. So if we had a patient come in, they wouldn't be in acute respiratory distress. So we wouldn't kind of be seeing them in this setting unless they'd ruptured, in which case they've got a pneumo.
Mm.
But a bulla itself would probably be an air-filled region surrounded by normal lung. It's very rarely right at the periphery of the lung unless it's gotten so big that it's pushed the lung kind of out of the way. And it's actually going to be air-filled, so you're not going to be sticking a needle in it.
Mm. So, but it'll look different to what this image is. It wouldn't look the same.
No, it will just look, most of the time, you're just going to see aerated lung and a normal pleural line because
Okay.
it's under the surface of the lung. So the only reason why a bulla would push right out to the edge is if it had gotten so big that it pushed the lung out of the way, or it had gone right kind of to the edge of the lung. But it's still only just going to look like aerated lung moving to the edge of the, because they don't actually really have thick walls or anything. Good question. Now, Helen's favorite, my favorite. Let's talk about the heart. What can we learn about the heart when we're doing our POCUS?
I mean, I just look at LAO. I don't always get it, but I try for it, especially in cats, because when they come into, like when they come in as respiratory distress to figure out whether this is respiratory disease or cardiac disease, I think it's one of the, I have used it a lot, and I don't necessarily, I'm not actually aiming for, because I don't know how to do an echo. I'm not aiming for a absolute number. I'm just eyeballing it to see, is it, because if it's double the size, then I'm just like, it's a cardiac failure.
Yes, I completely agree with that use of the LAAO ratio. This has been a kind of topic of discussion. So in a laboratory test, if you run the same sample 10 times and you've got more than 5-10% variation in the results that come out, then you say, okay, that's not a test that we should run. It's not accurate enough. And I would say that the variation we see in the LAA to AO ratio is profound. It's up to 50%, depending on the user. And I can do this LAAO in the same patient, and usually it's kind of ballpark, but it's often outside of 10% because the measurements we're dealing with are so small, particularly in cats. The margins are huge. So actually, the LAAO is not a really super accurate test. There's a lot of problems with it if you've got the angle slightly wrong. So when you're using it to sort of say, well, the left atrium was 0.3 millimeters bigger than it should be, that's not the patient in heart failure. So whilst that, there might be mild left atriomegaly, the patients in heart failure typically have profound left atriomegaly. So like you say, if you get used to looking at those normal ones and you say, well, I'm pretty used to those ratios, and then you see one where that left atrium is double the size it should be, you can say, yes, congestive failure is very high on my list here. Might be congestive failure and pneumonia, but congestive failure is very high on my list, or imminent if not present. So I would encourage everybody to get really familiar with looking at the LAAO, but also not get too caught up on being really, really, really accurate about it, if that makes sense. It's your impression that's going to count in an emergency situation. So I put this image in because I really like visualizing how the heart sits on a radiograph, which we're all so familiar with, and then how we're moving the probe through the heart relative to that normal anatomy. So what I typically do, you're looking at the heart in cross-section in this setting. So our probe is, so let's say the animal is in sternum. Our probe is basically you're going on right at the sternum where you can feel that apex beat, and the light is pointing towards the head. So you can see that kind of axis on the image here. Your probe is just directly across the chest. And if you then look at how those lines are moving up the heart, we've got to move slightly cranially to catch that. So you can do that with a combination of stepping or sliding that probe up, but you're going to hit lung if you think about where the lung sits when you get to about this level. So we're kind of probably going to have to go step, slide, and then tilt, right? To look up at the base of the heart. So if you put your probe on right down at the sternum, you're going to be looking straight through the apex of the heart, and you're going to see this. Pretty much nothing. It's all going to be solid tissue. Then you're going to slide slightly more dorsally, and you're going to catch the very beginning of the left ventricle. The lumen of the left ventricle looks like a mushroom. And the papillary muscles here. Can everybody imagine that? And then you're going to slide slightly more dorsally. And you're going to see a bigger mushroom as you're heading towards the largest part of the ventricle. And then you're going to slide slightly more dorsally or start to tilt at this point. And you're going to see your mushroom view right behind the mitral valve. So if you kind of just kept on sliding, you'd see the mitral valve, which is this one here. And you obviously know it's the mitral valve because it's going like this, in and out of your image. So then you want to kind of slide back to this view. And this is actually the view that we get our M mode echo view on. So if you're looking for like DCM or something like that, sometimes you just see this heart just going like this instead of like this. And you can actually make a really like quite good subjective assessment of, okay, there's probably like primary systolic dysfunction here and volume overload based on the appearance of that mushroom.
Yep.
Are you going via the right side of the chest?
Beg your pardon?
Are you putting the probe on the right or the left side?
I do it. You can actually, in theory, do it from either side, but these views are from the right. So see how the right, I haven't talked about the right ventricle at all because who cares about the right ventricle? No, just kidding. So the right ventricle is closest to the probe. So it's wrapping in a crescent moon shape over the top of the left ventricle. Why does the right ventricle wrap around the left ventricle?
Is it just because the muscle wall?
Yeah.
Is more.
Yeah. Exactly. Yeah. So what that correlates with is actually the pressure within the chambers. So the left ventricle operates under such high pressure. So it's directly correlated to the systolic blood pressure in systole. So we need to have a really thick muscle wall to generate that pressure. And then if you've got 120 on one side of the heart and then 30, it's just the 30 is just going to wrap around the 120, isn't it? On the other side. So that's why it's kind of ended up in that kind of crescent moon shape. But it does actually make the right side of the heart very difficult to assess because it's often, particularly when they're volume overloaded, it's often just like a slip of a thing around the left ventricle. So I look from the right, you got a bigger window from the right, Jesslyn. So the right ventricle is wrapping around here. And as you head more dorsally towards the base of the heart, dorsally and cranially towards the base of the heart, you're going to go through that mitral valve. Usually don't see the tricuspid until up here. Up here, sorry. So this is reversed from, we do echoes inverted. You know what I mean? So they're in a POCUS exam, you've got your probe, your light pointing towards the head. And in an echocardiographic exam, you've actually got the light still pointing towards the head, but the standard is that the image is reversed. So I get quite backwards when I'm looking at the LAAO this way. I'm like, no. Anyway, so we're going to slide up towards the base of the heart. And that's when we're going to see, as soon as we've moved through that mitral valve flapping around, we're going to see our Mercedes sign. This makes it look so easy to line up that aortic valve. It's really hard, and most probes don't have amazing resolution for cardiac, particularly in an emergency setting for cardiac valves. So try and make the aorta as circular as you can and try and see something flashing in and out, because the only thing flashing in and out should be valve, and you're probably at the level of the valve if you're lacking resolution. And then does everybody know how you would take a measurement for the LAAO? If you were going to do it properly? Yeah. I saw Bridget do it just
Right.
like
I don't know if it's proper, but yeah, I just like measure like this. Like, I don't
Yeah.
know, sure.
there's actually two
Isn't
different...
it you should actually measure when the valve is open? But I like I said, I'm not really looking at the valve or anything. I'm just eyeballing just to make sure. That's why.
So you should ideally do it when the valve is closed.
Closed.
Closed, yeah. So you want to see your Mercedes sign, which means that the valve is closed. And then there's two different ways of, like, very well published normal and the normal ranges and stuff, two different ways of doing it. But the way that I do it is you do a line straight down through that aspect of the valve that points directly at the left atrium, and then straight across, completely parallel with that line. And then so you've got two lines like this, and then you work out the ratio of a LA to AO. So then if you do that in 100 dogs, just slide up the heart and get used to what normal looks like, you're going to get really comfortable with saying, okay, well, that looks like it's a very full heart, or that looks like it's a very empty heart, or that left atrium looks subjectively a lot bigger than the aorta. I'm going to do a measurement of that one. So just, you can do that in 2 minutes, learning to slide up the heart like that. And if you get really familiar with it, it just becomes a lot less overwhelming. And go back to this picture, because it makes it so much easier to conceive where you are and what you're looking at. If that makes sense? To me, anyway. Obviously, everybody learns differently, but. Okay. So this is a pretty standard pericardial effusion. It's actually not a pretty standard one. It's a very large volume pericardial effusion. So we've got the probe on the right side of the chest, and instead of seeing the heart right up against the chest, we've got fluid. That's pretty much all there is to a pericardial effusion. I can't think of anything else to tell you. What else do you want to know? It's one of the easier things, like you can't really miss it, basically. So this is a picture of the LAAO from not a cardiology textbook, from an emergency medicine textbook, and see how poor resolution is of these valves here. So this is a textbook image. This is what somebody's taken to put in a textbook. So don't think it's going to look like their diagram on the other page. So we're going to measure, we're going to say, okay, there's one valve here, the other one must be there. So we're going to measure across here. And then we're also going to measure to about here, because if I draw a line between these two sections, you see, So what actually happens with the LAAO measurement often is when they're congested, the pulmonary veins are trying to empty into the left atrium, and they're under a bit of pressure and they get quite distended. And they line up to exactly where you want your line to end from your, like if you're going parallel to the aortic valve. So you end up like overestimating and measuring down here. So that's where I want you to just cross-check and say, it actually didn't look that big. Like I'm getting an LAAO of 2.5, but subjectively in long axis, it didn't look that big to me, or it looked like the size of Texas, and this is probably accurate and probably doesn't matter either way, the dog's in heart failure. So definitely your first impression rather than the measurement is going to count for a lot once you've looked at a few. I would also encourage everybody to get used to you looking in cross-section at that section of the heart, the LAAO section. Turn your probe dorsally. So rather than being craniocaudal, go dorsoventral. And just get used to seeing what the heart looks like in long axis. I love doing a left atrial measurement in long axis just to compare to my short axis measurement, because it's like that quality control thing. Because as I said, there's that variability in that LAAO measurement. Even when you've done a million of them, it's just the anatomical variations mean the angles are different in different animals and stuff. So it just lets me kind of do a bit of quality control. And if I see an atrium that looks like this, 3 times the size of the right atrium, for example, I'm going, okay, well, that's probably like, it's probably abnormal if it's that much bigger than the right atrium. So I think that's a really nice view to get used to getting as well. Okay. Now, we've done the whole tutorial on teeth fast now. Sorry. So let's talk quickly about not annoying pathologists. Does anybody have any specific kind of questions around like preparing slides and stuff like that?
I aspirated a mediastinal mass on Friday, and I really annoyed the pathologist because we like lies. It was really hard to aspirate. We had to use suction, which is unusual. And we thought we saw lymphocytes in house, so we sent it for flow cytometry too, and the flow cytometry was just completely non-diagnostic. There was 1% of cells intact or something. It was the first time that's happened. The first time that's happened to me. Yeah, it's like so frustrating. And even the cytology was non-diagnostic. More than 50% of the cells, she said, were lies. So that was really frustrating. It hasn't happened that badly before.
What size needle are you using?
Black 22.
That's pretty good.
Mm.
Like I wouldn't go much further than that in a thorax.
No, so I don't know what to suggest. I don't know whether we should just repeat it or I don't know. The pathologist suggested a core biopsy, but I haven't done that.
That's scary. Was it a cystic mass?
Hmm?
Was it a cystic?
No, it looks pretty solid actually. And it was hard. It was weirdly hard to aspirate.
Yeah.
Mm.
Interesting.
So anyway, the pathologist didn't like me, but I also didn't like her. It was all about
Mutual. Yeah. So there's a couple of things that just happens all the time. And these are high stakes samples, right? Like CSF, joint taps, craniomegaspinal, pulmonary aspirates. Like when you've got a sonographer that's done the sampling and stuff like that, these are not tests you can just repeat, which is that's if a pathologist sends me back results saying consider repeating, I'm like struggling not to put my red fingers up at them. Especially the CSF, I'm like, oh, I started them on pred immediately after taking the sample. So a couple of things in that that I do based on calling the pathologist and saying, please give me something. What can I do to make sure this doesn't happen again? So using a bigger needle obviously damages the cells less, but you need to balance that with risk to the patient, right? So like I usually use blue needles. So black, like I wouldn't go much bigger than I wouldn't go any bigger than a black in a thorax typically. We have done true cuts of mediastinal masses, but only when I'm really comfortable. There's not a huge amount of blood flow. They're big enough, like you can't miss them, and they're not cystic in appearance. And I know they're not thyroid. So the nice thing sometimes about an inconclusive cytology, it's like thyroid carcinoma exfoliates really well. So it's probably not that. Lymphoma exfoliates really well.
Yeah, usually. Yeah.
Yeah. So you're kind of left with thymoma. Sometimes an inconclusive cytology is kind of helpful in some ways, in that like it's probably going to be either a sarcoma or something that doesn't exfoliate that well. So size of the needle is one thing that you can do. Simone mentioned suction versus not suction. And I got the impression that you try without suction, and then when you don't get anything, you use suction. I've spoken to countless pathologists, and they would rather some cells than no cells. So there's just, it's a compromise, isn't it? Sometimes you've got to. But I always do my first samples with no suction, just to make sure that we're kind of giving it a chance to like get the best cell preservation. If you are suspicious of, I'm going to go into this later. Sorry. Spraying the slides. How do you get the material out of the needle onto the slide?
I take the needle off, put some air in the syringe, and then try and be gentle.
Yeah. Do you spray or do you dribble?
It depends. I suppose it depends what's in there. Like sometimes it kind of gets a bit stuck and you kind of have to spray.
Yeah, I agree.
I think high blast, which is very wrong clearly then.
High blast. Well, I've done high blast. Based on feedback from a lot of pathologists, they would rather the thinnest spray of cells you can get. Is what like the vast majority of pathologists have kind of that I've spoken to have said. But the textbook clearly says don't spray it, dribble it, and smear it. But so I think there's just a bit of personal preference, and you almost need to know what you're going to get to know how to prepare the slide. Like, is it a carcinoma? Is it a lymphoma? Because very aggressive tumor cells or very active tumor cells are very fragile. If you smear them, if you spray them, they're going to get damaged in the process. So, for example, high-grade lympho, large cell lympho, the pathologists hate it when you smear them because you actually smear their cytoplasm off. So those ones I want to make a monolayer by spraying, but I want to spray gently, or I want to just collect 3 cells at a time and put them all on the one slide in separate little. It's just impossible.
What do you mean by spraying? Can you demonstrate what you're saying? Like, what do you mean by spraying?
If you put like air in your syringe and I kind of lay my needle down kind of flat, or like so that the bevel's kind of pointing down so that the cells kind of come out, bounce off the bevel and then land on the slide. Does that make sense?
Mm.
I do it like hard, fast.
And go hard and fast. I think that's the
Yeah.
Mm.
it's
Otherwise,
to
I
drip
just end up in
pages, like,
shock. Yeah.
If there was some in the hub of the needle and you could get it directly, it'd be better, wouldn't it? But that's not always possible.
And you've also got to smear it. Like if you've got enough to be visible in the hub, you've then got to smear it out.
Yeah.
Yeah. So the pathologist, there's a nice clinician's brief about how they like cells to be smeared. And they sort of say, do the like hold the slide like this and then put a slide across very lightly smear. Every single time I do that, it goes on, and then I'm like
Like a vacuum.
the vacuum. So annoying. Energy actually said do it like a blood smear, which actually sits better with me. I feel like I can be more gentle doing it that way than the thing. So I'm going to go with that one for a while and see what sort of pathologist feedback I get to my reports.
I like when they give you good feedback. I feel like they rarely do, but when they do, you're like, oh, that's
it's
nice.
so rewarding, isn't it? Yeah. I did an endoscopy yesterday and I'm like looking forward to the minuscule samples of amputated villi. Yeah. Anyway, so what about fluid? How should we be processing fluid to maximize the diagnostic capacity?
Cytology depends on the fluid, like where have you collected this from? Because like if it's respiratory, then you may want to do PCR as well as culture, as well as cytology.
Yeah. So essentially, if you've got a reasonable volume of fluid, the pathologists just say put it in everything you can. So put some in EDTA, particularly if it's turbid, like if you've got suspicious of a high cell count, put some in EDTA, put some in a plain tube. And if you're doing a PCR, put it in a separate plain tube, because as soon as they've opened it in the lab, they can't then guarantee that the PCR is going to be like accurate sort of thing. So they've got their own ways of dealing with that, different labs processing to maximize its accuracy. But they do like it to be collected in a separate tube if you can, if you're doing a cytology and a, if you've got heaps of fluid, often you've just got a tiny bit. What about fluid for culture? Anaerobic culture. What are we going to do?
So I think last time I did one, I just put some drops of fluid onto a swab and sent the swab.
Yep, I think it's a really good idea. You know those swabs, the ones that come in the medium?
Like with the gel kind of at the end?
Yes. Yeah. I found when you try and dribble fluid onto those swabs, they're actually quite like water resistant, and the fluid often kind of dribbles off. So what I've started doing is spraying the fluid directly into the medium and then swabbing the inside of the tube on the way in. And then kind of pick it all up on the way in. It's all kind of sterile and like,
in the tube.
and rather than dribbling it like over here and losing some, I found that works quite well, and I'm more likely to get positive cultures. And then another thing you can do is put it in an anaerobic blood culture bottle if you've got enough fluid. Or one of those little urine pots, like the sterile ones. If you've got 5 mils and can fill it right to the top, you can get anaerobic culture on that as well.
What about a red vacutainer? That'd be it's evacuated.
It is, but they've got like clot activator in it.
Oh yes.
Yeah, which is annoying. We really need just an empty vacutainer for exactly this purpose. We might have to wrap up there. And I've got no idea what we're talking about next time. It is ECG and echo. Oh, that's so fun. Yay. For sure. No, not your thing.
I want to learn the echo, and I tried reading Ettinger.
Yeah.
It just puts me to sleep. It's so bloody dry. It's so
It's
like I
really-
want to learn at least the basics, and I just don't know where to learn from because I find it really boring.
Yeah. I think emergency echo is a great place to start.
Yeah, there is a few good YouTube videos too.
Okay.
Yeah.
Which is like Google Echo Dog.
Yeah. Just YouTube it, yeah.
So we'll go through it. I'll try and do some videos and stuff for that one. And we'll go through a few cases instead of doing just textbook dry stuff. Cool. All right. Nice to see you all.
Thanks.
Nice
Thanks,
day,
everyone.
everyone.
Bye, everyone.
Thank you, Anna. That was
Thank you.
fantastic, as usual.